Good evening, everyone. I, Dr. Sonia, welcome you all in the evening session of the conference, Nspr 2021.
Yeah.
The theme of the conference is Professional Ethics in Practice of Rehabilitation. I am thankful for eminent speakers and guests
School of Nursing SN.
being with us to share
College of Nursing.
knowledge and experience.
Chairman.
Without taking much time, I invite our first speaker, Professor of Medicine at Mayo Graduate School of Medicine. His topic is Aerosol Mitigation Lessons Learned During the COVID-19 pandemic. Dr. Bhuttal, please share your views with the audience. Dr. Bhuttal, please.
Good morning.
Professor.
Is it possible to share my screen?
Yes, sir. Start, sir.
Constituted.
Yes, Dr. Bhuttal, please start.
Saying the screen share is disabled by.
Okay, right, sir. Right. Done, sir.
Do it again.
Good morning, and thank you for the invitation. So my topic today is aerosol mitigation, the lessons that we learned during COVID pandemic. So we at Mayo Clinic in Rochester do about 50,000 interventional endoscopies in our particular area. And last year in March with COVID, we almost completely halted down to only emergent procedures. And the key there was, as you all know, the infection rate of COVID-19 is about 8.3% among healthcare workers who deal with COVID patients versus 3.4% in those who do not work with the COVID-19 patients. Many of the procedures such as emergency intubation or doing procedures that are involving the oropharynx generate aerosol, and the aerosol carries the viral particles to cause infection. Unfortunately, in the early part of the pandemic, due to high utilization of the personal protective equipment, worldwide there was a shortage of PPE, and aerosol generating procedures were disrupting this supply chain. In addition to that, every room where the aerosol is generated, it can hang around in the room for a long time. So there was a major procedural flow disruptions that happened because you had to give CDC mandated downtime to mitigate the aerosol or clear the aerosol. So early on, we asked as appropriately what models can be used, because this is after Legionnaire's pneumonia 30-40 years down the road. This was something new that we needed new models, new testing strategies, and mitigation strategies. So so first part of my talk will talk about how we developed the models. So we took a mannequin, and in the throat of the mannequin, we put a nebulizer. The nebulizer sends the saline fume, which is like aerosol. And we also had a fluorescent dye in it so that we can see how the aerosols spread throughout the room. And we also had the patient or patient equivalent, which is mannequin, with a mask on to see if we can mitigate the aerosol at the source. And this is where, when we put a scope through the mask and you see all these dotted particles, those are the endoscopic view of aerosol. There was a paper published in New England Journal of Medicine that looked at placement of a plexiglass around the patient to contain the aerosol, where the air comes from one side, or in this case, it was oxygen, and the suction on the other side at 400 millimeter of mercury negative pressure to create a laminar flow. And we tested that device with holes, without holes, also source control using the mask that was tightly fitted on the patient with a suction connected. In this process, we developed we called it aerosol mitigation gear, or AMG. So the standard mask that anesthesia team uses during intubating a patient or during surgery, we took that and modified it with a couple of air seals. Through one, we intubated the mannequin. This is actually the mannequin. And then through the second one, we used our scopes that typically will generate aerosol. And through the third port, we connected a suction device that had a viral particle filter. We then tested on ourselves the different approaches where the scope was tested in presence of plexiglass, as well as a mask with a negative suction to control it on site. The aerosol testing is also challenging. So the device that we used was Aerosol AeroTrack, which can measure particle from 0.3 to 5 micron, which is the coronavirus aerosol particles. It can detect as low as at a flow rate of 0.1 CFM, and the variability is small. For 0.45 micron, it's 100% sensitive, can detect up to very high number of particles without the drop. And as I said, we use the nebulizer to generate the aerosol. So in our first testing, we wanted to know if our rooms need to sit for an hour between every procedure to clear the aerosol. Fortunately, contrary to what was believed in the literature, because the literature was about 30 years old that CDC put the guidance on, all recent operating rooms or procedure rooms worldwide have now the laminar flow type of requirement. And we tested the different part of the room by generating aerosol with the same mannequin, which is the sources here. And the green here is the place where most of us will have our face. And if you notice, at the face level, there was very high aerosol content, and all that aerosol content got pushed towards the wheel end of the bed. Nearly, so on an average in room without generating aerosol, there was 760 particles, but with this, there were close to 150,000 particles. But as you can see at the level of face, it was 598. So it's even lower than what we find elsewhere in the room. 6 inch from the floor also had a higher concentrations. However, tabletop where we sit and do our work was near the room baseline particle count, and air return where the air is suctioned also had a high count. So if one avoids these areas and if it doesn't block these areas, rooms are very effective. And here is the, after generating particle, the room actually essentially within 5 to 7 minutes reached within the 99.9% of aerosol clearance. So we were very fortunate, and this led to a practice change from 1 hour of room idling to about 15 minutes, 10 to 15 minutes. The other impact of aerosol generation, we wanted to test our mask, if we can control the aerosol at the source. So this is what I was telling you, that we had a regular mask here, where we put two insertion ports that are sealed, one used for putting the tube in the respiratory system, another one for endoscope for nasal procedures or oropharyngeal procedures or procedures in the GI tract, gastrointestinal tract. And here is the disposable high efficiency filter that is connected to negative suction. This is on the mannequin. If we have aerosol on with the with the saline, but if we have suction off, you see the aerosol are leaking around, which will be contaminating the room. But if we turn the air on or suction on, it cleared, as you see here, versus this, and there is no leakage around the mask. This is when the scope is inside. If the aerosol on is and the suction is off, you see a lot of white particle, but as soon as we turn the suction on, it clears all the aerosol right at the source. We also did the timed experiments where at baseline at the room, it was 773 particles. When we turned when we had the aerosol on, but the plexiglass suction was on, the particle did increase, almost doubled, but still were not excessively high. But if there is no suction on the plexiglass, you can see almost 130,000 particles there. Turning the plexiglass on after turning the aerosol was only partially effective. As you can see, even with the suction on in plexiglass and aerosol on, ongoing coughing or gagging by the patient will continue to produce high number of particles. But in the same scenario, if we put the suction on the mask, it actually brought down the particle count even lower than the than what we saw in the plexiglass. And this is very fast and effective. So here, as soon as you turn the suction on, very high count. Within 5 seconds, it's 1/3, and then within 15 seconds, it's 15 seconds or so, it is down to baseline. So what we found, and then we simplified it more. We just got a different type of mask in which the intubation can happen from here. The negative suction can be from here, and there's only one side port there to pass the scopes. And this we tested in our institutional review board study to see if we can contain, and we were very effective in containing. So I'll end my talk with a few more slides. As you all know, the easiest way to mitigate the exposure risk to the persons in the room is using the PPE. These equipments are expensive and were not extensively available. Using the standard N95 mask, if you keep them for 7-8 hours of procedures, they increase the work of breathing, fatigue, headache, asthma, acne, and allergic reactions. So what we did is we took these standard N95 masks and connected either a negative suction here, which is a battery operated, very low 17 decibel sound, airflow there was 1.2 CFM, and these are portable. They fit right on the face shield, and here there is a tiny little hole, and we tested them for aerosol. Alternatively, we used a port that has a high power magnet, and in this high power magnet, we had the second high power magnet within the mask and connected that way. You can suction it through this and take the air out. So we create a negative pressure. So what we found is that if you do not have N95 ventilation, you're having almost close to 41 millimeter of mercury of CO2, which is very high. Typically, we breathe 1% or 2%. On the regular mask, you breathe about 15 to 20%. So if we create a positive pressure ventilation of the mask, we brought it down to 22. And if we created the negative ventilation in the mask, we brought it down to 18. And we also noted that the overall mask acceptance by putting these negative and positive pressure ventilatory approaches, subjects were much more comfortable using these masks. So these are a low-cost alternative to a PEPR or the high expense device. So the lessons learned here are the collaborations were key with the Department of Engineering and others to develop and understand what is the threat, how can we mitigate it, how do we prevent the COVID transmission. We deployed the novel aerosol mitigation strategies, and they were effective. We devised the negative and positive pressure ventilated mask to help mask fatigue. We're now better prepared, and many of these devices are in the process of getting to the publications and eventually to FDA approval. So I'll stop there, and thank you for the invitation again. If you have questions, I can answer now. I have a procedure that I'll be starting shortly.
Now I welcome Dr. Riputaman from Canada. He is physician and Director of Research of Human and Children Health Program at Toronto. His topic is engaging communities in designing development interventions, a Canadian perspective. I request Dr. Riputaman to share his experience with us. Dr. Riputaman, please.
Is Dr. Riputaman there? If not, then maybe I can just comment briefly. I am Dr. Prasannanshu, chairing this session. And first of all, I would say that Dr. Navtej, that this paper was really very interesting, very useful, and it shows that what innovation can do. Congratulations, Dr.
Thank you, Dr. Navi.
I think it is going to help in the pandemic and many other such situations. It is going to go a long way in that. If Dr. Riputaman Minhas is not there, then perhaps we can have a question if there is anyone. If anyone wants to ask a question, we can have a quick 1 or 2 questions because Dr. Navtej is engaged after that. And after that, we can perhaps skip to the third speaker if the second speaker is not there. So you may raise your hand if you have a question. If it is okay, then we can go to Dr. Jessica Stewart if she's ready.
Thank you, Dr. Pramansu. I'm going to take off. It was very kind of you to invite and allow me to share our work. Thank you.
Thank you very much. Thanks for sharing this wonderful work. Thanks. Dr. Jessica, are you there? Is Dr. William Lane there with us? Dr. Olaf Krauss?
I hope.
It is fine in case the speakers are having some technical problem or they will take some time to join. We can have a quick discussion in the meanwhile because the topics are really very interesting.
I request Dr. Dharamvi to speak something. He is the chairperson of the session. He is assistant professor, PGI MER Chandigarh in ENT department, and Professor Dr. Pranshu. He is professor of National Law University, New Delhi, as he has just talked about himself. He is one of the most eminent researcher, as well as he's working in the field of linguistics, and he has been awarded with many different achievements, and he's one of the most prominent speaker in this area. He has been doing a lot of work in the field of linguistics, and Dr. Dharamvi in the field of speech and audiology. And I think, Dr. Dharamvi, would you say something about your field and its role in the field of rehabilitation?
Thank you, Dr. Nina ji. It's really excellent that since morning we are running this conference. In the morning, as we see, Saab has told so many things about the rehabilitation, even in the pulmonary. That was especially thing he has just mentioned about the rehabilitation in all, not only this pulmonary, even economic or other things are also involved in which we need the rehab. Particularly, as you have told, my specialization, we are having the doing the rehabilitation in this phasic cases. As if the patient have some stroke, then we are just giving the speech therapy to those aphasic patients. Aphasia is basically the loss of language, this acquired. Many times it's can be in the childhood that can happen, but mostly whenever the person is having the right hemiplasia, then the patient get total loss of language. Similarly, in our speech, the many patient, if somebody get that some phobia or depression many time, then that they get aphonia. Aphonia is basically the loss of phonation only, not this particularly that language, but they are able to phonate uh, with that breath only, but they are not able to produce the louder sound. Okay, so the basic in those patients, in aphasia and in aphonia, the family is the main important having a role, because if the family is supporting to these two type of patients, then only you can rehabilitate. Otherwise, you cannot rehabilitate these two type of a main patient. Otherwise, I agree with other people also that the supportive system in rehabilitation is more required than anything else. If you just see that in any disease, allopathic disease, you have only 20% allopathy medicine, which can cure that any disease. But the 80% you require the rehabilitation. Then only you can improve these patients. So the other, there are autistic children we are dealing in our department. As next, I think next speaker is from that area only, who is going to talk about that. And Dr. Gurpreet, who is really helping to us to arrange all these speakers from the USA, Canada, and UK. He is really doing a lot of work for these autistic children. And his wife is also a doctor. And both of them are really serving here in India. Initially, they were serving to these children, but now they are serving to in Canada, the other patients. So, and even in geriatric population, you require too much rehabilitation. If we see that whenever somebody get old, that physical activities, they are not able to do as much as initially in the young age they were doing. So here, whenever we have seen in old age home, they have the some supportive systems, but in the government setup, they are not able to provide up to date things as compared to the private. If we just see, I have opportunity to go to abroad, and where the rehab centers are there, like they give that the name as the residential care service center, in which they just keep the mentally ill patients and they provide each and everything, medical as well as other activities, sport, in their that centers. But in India, I have not seen even a single that type of residential care center in my knowledge where I can see. Even I have seen in our PJ, if you just see, all of us have gone through many time in this our emergency ward. Whenever any accidental case comes, head injury cases comes, or any tumor cases comes, then they just operate. They just do the initial primary health care, but after that they just discharge to those patients, and they are not able to handle their patients at home. So many times they just get that problem at home. So anything else? If Dr. Nina, you want to ask from me, then I am here.
It's really nice, and the way you have been explaining the things and how they are managed, it's really wonderful. And we all, if we work together in the field of rehabilitation, I think that is more required in case of Indian population, because in other countries I have seen, we have moved around in different countries, and we have seen that this rehabilitation is the routine mainstream part of the treatment, as well as your bringing them, everybody bringing them back to the normal life. But in India, we certainly some of the important things we miss, and the sometimes very emotional parts of the family system that comes in the way, that we don't want rehabilitation standards, we want only everybody to be at home, and we that is why sometimes we lack the expertise in that field, and we start treating our own way. So sometimes it works and then sometimes it doesn't work. So I think association for such type of awareness conferences will really help the population to go ahead with better ideas of rehabilitation in different areas. Thank you so much, sir, for giving beautiful information and the talk that we have shared with our audience, as well as we would like to share with other people also. I hand over to Dr. Sonia Bhatta, the moderator of this program.
Thank you, Nima ma'am. Now I welcome Dr. Ripudaman from Canada. He is pediatrician and Director of Research of Human and Children Health Program at Toronto. His topic is engaging communities in designing development interventions, a Canadian perspective. I request Dr. Ripudaman to share his experience with us. Dr. Ripudaman, please.
Hello, thank you so much for the invitation to the committee and also for organizing such a wonderful event. I'm just going to share my slides. There we go. Is that showing up for you? Okay, thank you so much. So as was mentioned, my name is Dr. Ripudaman Singh Manhas. I'm a developmental pediatrician, and I am the Director of Research in the Department of Pediatrics at St. Michael's Hospital at the University of Toronto. And it's particularly meaningful for me to be able to speak today with your group because although I've resettled in Canada, I was born in Chandigarh and have close ties there. I'm very excited to hear about the work that's being done in the area where I was born and grew up or for my first few years. And also I've been hearing about the project in Mohali, Chandigarh, around a rehabilitation center that may be in the works there as well. So it's very exciting for me to share some of my perspectives from a Canadian space. In particular, so at St. Michael's Hospital at the University of Toronto, we work in the inner city. So we see a lot of families that are facing marginalization in different ways. And so I'm going to speak a little bit about that as we think about interventions for families, for children, and thinking about how and why we should be engaging with them. So in the next few minutes as a part of our conversation, I hope to highlight some key concepts of community engagement in developmental and overall pediatrics practice and research, to discuss a little bit about what we know and a couple of the projects that I'm engaged with right now with the community, and also to review program considerations for community engagement in child development and disability-related work. When coming into a conversation like this, I think it's important, we often will declare our financial conflicts of interest. However, I think it's also important for us to think about our own personal journeys and perspectives, experiences that we bring in as we think about engaging with communities in designing healthcare interventions or research projects as well. And so when I reflect on this, and I know when we talk about this in a Canadian context, I do think about how my work is impacted and informed by my experiences. So as a healthcare provider and a consumer of the healthcare system, as a cis male, a settler in Canada, a person of color, I'm a parent. So certainly that impacts my education, healthcare. I'm stably housed and employed, and I'm a family member of individuals who have chronic health issues, mental health diagnoses, developmental disorders, and individuals who would self-identify as refugees or internally displaced peoples. And so I'll pause there just for a moment as I talk through that for you to think about yourself as well. And when you come in terms of your privilege or your disadvantage, your centeredness, or your marginalization as well. And we'll come back to some of these concepts as well as we think about this. The other thing I think that's important as a part of approaching healthcare is really thinking about where we think of healthcare or how we think it ought to be delivered and the frameworks that we use in our mind. So as a part of the way that many of us are trained in different parts of the world, particularly in countries that have European roots in terms of some of our education systems, we may identify or think of healthcare as being kind of like this painting, the doctor's office. So this is a European or American doctor's office with this pediatrician who's kind of friendly and looking around the room and meeting his patients. Although all that seems quite pleasant and fun. It would be, we would be kind of reminded that no one's wearing a mask. There's a dog inside the waiting room. There's a puppy there. There's a man smoking inside. So some of these concepts have changed over time, even though it does seem quite pleasant. And then on the other side of the slide, we have a photograph that was from the Los Angeles Times newspaper, which was a COVID screening center. And there we see people waiting to be screened as well. And this was in Delhi as well. So this is so important for us to think about in terms of how we design healthcare and really the perspectives we bring and also our patients' experiences and expectations as well in terms of what is that experience going to be like and what is that interaction with the provider going to be like as well. And when we think about, there's been a lot of conversations globally around the idea of equity, and I'll talk a little bit about that, but really the idea of in a way that is meaningful, relevant, and accessible for the patients we see. And certainly in North America, we've been having a lot of conversations over the past year around the impacts of race, income, and other pieces around how we identify ourselves and our experiences as well. And so there's been a lot of work around, or at least conversations and work starting around the child development sector, around the disability sector, and for families that experience marginalization in multiple ways. And there's this concept we call intersectionality. So the idea of someone being from a poor background or a racialized background, that marginalization is even worse or further compounded by if they do have a disability or if they have a child with a disability as well, and further on from there. So when we think about these words, you may be familiar with this, but I thought I would reiterate this, and I also like these illustrations as a pediatrician. So there's these concepts that we talk about, say inequality. So in this picture, we have an apple tree, which is slightly crooked, and we have two children that are waiting for that apple, that resource to come to them. And so you could think of that as being a healthcare sort of experience, perhaps. So we have the one tree to whom the tree is slanted, and we see the apple falling down to him, whereas the other child is looking at puzzled because he's not receiving the same opportunity or the same resource. Moving to the side, we see equality. So equality would be more of this concept than, hey, you know what, we will give all of the people the same tools and assistance. So that would be, I think, where a lot of healthcare in the world is right now, where the idea is that we try to give the same, and certainly within a Canadian system where we have publicly funded healthcare, we would try to give everyone as much as possible similar resources. However, you see that the child that is underneath the slope of the tree is much more easily able to access resources, whereas the other child is not, because he needs more. The tree is slanted away from him. Then there's this word equity, which we talk about a lot now. And that's the idea, is that each person should be assessed in their unique context of what they need, and whether the tree slants towards or away from them, so that they can access things equally or with equity. And finally, there's this word justice, which I think is something we would all like to work towards, particularly as academics and in healthcare, where the idea is then, rather than looking at what does everybody need, how do we fix the system? And you see that this tree that was otherwise slanted to one side has now been righted upwards. And so you have both a fixing of the system and then also ladders that are equal to everyone based on what they need, so they can access these resources. So I think these concepts are quite important as we think about how we deliver care. And something that I think about with the way that we deliver our resources within our context, and I think, again, many parts of the world, is really thinking about who is this current system built to serve. So often we need a family, if they want their child to be assessed, to have a referral, which requires the family to have a certain level of self-advocacy, social awareness, agency, and freedom from stigma. We need you to wait either on a wait list or in a waiting room, which can be difficult for families who suffer from challenges with power dynamics or with anxiety. We will call you. So in English speaking spaces, language can be a barrier, even if there's an interpreter. We also require you to have access to a phone, voicemail, and technology. We will mail you, which may be difficult for families who are not stably housed. We expect you to remember, which again hinges on parental executive functioning. We expect you to be on time. We expect you to come to us, usually, although COVID has changed how we deliver virtual care. But for multiple daytime appointments, that can be hard for parents who are wage workers or have other children that need to be picked up or dropped off from school. We ask you to come to us, which requires transportation, and parking can be quite expensive also for those who want to drive. And for the virtual visits that we've been doing also, there's a need to have a certain level of internet access, computer literacy as well. Many families have been feeling uncomfortable about sharing their home on a video screen as well, for fear of how they might be viewed. And we use normed tools that are based on a standard of primarily English speaking and white children from North America or Europe as well. So thinking about how that might vary with the diagnostic tools that we use. And of course, we do this on our terms as healthcare providers. And we could kind of go on from there. And so really, how do these barriers disproportionately impact some families when we think about the way that that tree slants as well, especially if they have experiences of trauma or marginalization as well intergenerationally? And I really like this concept, and I'm going to ask you again to reflect on your community that you serve, wherever it may be. And there's this thing called the power flower. And so there's all of these different ways in which we think of how society tells us that you are valued. And so it could be things like your race or your skin shade, gender, geography, your caste, education, language, sexual preference, physical ability. And there's so many more petals you could add on to this flower. We call it the power flower. And the idea again is that some people are closer to the center and some people are further away. And in the center of that flower is really, we see a lot of the power, privilege, position, and the decision-making that comes. And we kind of joke that as a part of European colonialism, there's a lot of importing happening back to Europe, but a lot of exporting, including of some of these concepts, which have really continued on in many post-colonial societies as well, and continues to happen with media as well, furthering these disadvantages and these spectra. And so this brings up the question in terms of our context as healthcare providers and as academics, who designs the interventions and for whom? So classically, our interventions and our programs have been led by healthcare professionals, healthcare corporations, government and their agendas, and then also research agendas, research funders and academic institutions as well. but yet they're done to, for, about, or on a target population. And so I ask you to think about how this could be done more so rather than to, for, about, or on, but with the target population. And that's something that we know when we think about a community, whether it's a geographic community, a diagnostic community. So if we think about parents of children who have autism, for example, we know that those communities themselves, rather than, there is a really untapped resource there in terms of their own strengths, their knowledge of their barriers, the content of their lived reality as well. And also an importance to understand their health values and goals, communication needs, their interactions with larger institutions, whether it's academic, government, etc., education, for example, as well, and what is their capacity. And there's been a big movement towards more patient-oriented research, patient-integrated research, and community engagement around this. Because really we know that if we can involve communities as partners, that leads to better outcomes as well. And I'll speak to that in a moment. But we have been, I know within our institution and my projects, we've been trying to engage with community representatives and families as partners, all the way from mapping out initial concepts and designing our interventions, even applying for funding together as well, and then all the way to evaluation, dissemination, and then refinement in a very iterative way. So taking our model we come up with as a program back to those community advisory groups to refine it further as well. And so that's this concept of what we call community-based participatory research. And so the idea here is that as healthcare providers or as academics, we honor the community as an entity itself that has its own strengths and knowledge and power as an equal partner in the research and the healthcare program design process. So typically we see, I mean, on the slide here, we have these various colored arrows and rectangles below them. So I think a lot of our traditional approaches have been that we inform the community. So we say, we will make a decision on how we will deliver this, and we will keep you informed. However, as you kind of move across this spectrum of engagement of the community, true community-based participatory research is both collaborative and empowering for communities, where you ask them their needs, you take that and bring it together and synthesize that with the scientific know-how that we have, and try to put that together in a way that can then be created and handed over to the community to lead to more sustainability. And the reason we think this is helpful, and the science has shown us this, is that it enhances the relevance of research and program design to the community. It strengthens interventions in a cultural and local context. It enhances the reliability and validity of measurement tools. It improves response rates and recruitment, and you have more retention and less attrition. It increases accuracy and cultural sensitivity of the interpretation of findings. It increases the translation of evidence-based research, and leads to effective disseminations to impact public health and policy, and leads really to long-term improvement in research trust and rapport with the community as well. The challenge, of course, is that it takes longer. As you add more people into your team or into your decision-making process, and you kind of look at more of almost like a democratic sort of approach, it takes longer. But we know that in the long term, the efficacy and the relevance and the sustainability of these interventions are longer. And they save us money in the long term, even though it may cost more upfront. As a part of, in the last few minutes, I will mention a little bit of the work that I'm doing. So as a part of our intervention, or our team in the inner city in Toronto, we are embarking right now on a priority setting partnership. So we are creating an email survey that is launching now, and to all of our patients, and for families who speak different languages or may not be able to read because of limited literacy, we'll do telephone interviews as well. And they'll be offered the opportunity to share with us their priorities in terms of what we should be doing in terms of our pediatric research and our advocacy as well. The focus is on families that are experiencing marginalization, whose voices are otherwise typically not heard within the research realm or in the policymaking realm. It's mixed methods. So initially it'll be this survey-based, and then we'll move towards smaller focus groups and qualitative methods afterwards as well, and use this to update our research frameworks, both at St. Michael's Hospital and the University of Toronto, on how we engage with parents and what these priorities should be around pediatrics health, and then work towards creating a parent and family partner advocacy council as well. And many agencies are doing this now as we use their perspectives to advise and inform and oversee, and sometimes even provide approval before research projects can move forward to make sure that they are equitable and relevant to families. Another project that I'm working on right now is using, again, community-based participatory methods to create a parent support program for Canadian families that are of refugee background from different parts of the world, focusing on families who have children with autism or other developmental behavior disorders like global developmental delay. And we've gone through very intensive community engagement, both with families of refugee background and stakeholders and agencies that work with them. And we are now creating a program that will roll out in a virtual space as an online parent support program. And we were surprised. So speaking to the merits of CBPR, or community engagement. So initially, it was interesting to hear from families to say, you know what, the existing programs don't take my cultural context into perspective. Or some families felt triggered because many of these programs happen in a closed space or in a basement kind of unit of a community center or library, but that might be triggering for families who are of refugee background, who might have lived in a refugee camp or have trauma or PTSD as well. And so these are things we hadn't thought about and gained so much knowledge from the community around this, around what our program topics should be, what our facilitators might be, or what the barriers are to the current programs that exist, and also the logistics around how do we balance and look at their schedules and their priorities as well. And perhaps something that might be of interest to some of the people in the group is we have created an online social media platform. So if you're on social media, you can add us and please follow on Instagram or Facebook or even TikTok recently. And that's called Punjabi Kids Health. And I know COVID has really shown us that racialized communities, and particularly the South Asian community in North America, England, and Australia, have really suffered relating to COVID, where we see that the knowledge is different. And the research shows us that if you're getting health information from someone who looks like you and speaks like you, health outcomes are much better. And so we've created this online campaign with a community advisory council of Punjabi-speaking families and healthcare providers from across the world. Actually, we've got about 20 people on our expert bank. And so it's concepts both in English and in Punjabi. And so as a part of World Autism Day next week, we'll be launching an autism awareness campaign as well around this. With it, as I said, it's English and Punjabi, designed for families that are ethnically Punjabi and practitioners who work with them. We've had a lot of interest from teachers and psychologists who might be of other racial backgrounds, but work with South Asian families and are aimed at Indian nationals, but newcomers and migrants, and also those whose families migrated earlier, but continue to think about those cultural frameworks as they raise their children as well, from a general pediatrics perspective. And we have volunteers from the community as a part of this using health literacy frameworks. And we're creating a community advisory board, including parents, where then we can steer this to help with their needs. There's been a lot of interest, like I said, from school boards and therapists and psychologists, and including from Child Protection Services and also from the Children's Aid Society around how we can help families also be safer as well. So there will be an evaluation and a community engagement kind of approach as we think about how to tailor this to the needs of families moving forward. So I'll pause there as we wrap up, but I hope as a part of this brief presentation today that I can prompt you to think a little bit about the community that you serve and commit to learning more about their realities as well, to approach disparity with curiosity, not with judgment, to honor community's strengths, knowledge and values, and be prepared to think about really the why of why we do things and why we can try to do them better for the families that we serve as well. So I'll pause there.
Thank you, Dr. Ripudaman, for a wonderful talk. I invite anyone who would like to ask a question.
Hello. Thank you, Dr. Ripudaman.
Yes. Good evening, sir.
Good evening.
Dr. Ripudaman, sir, good evening. Sir, I am Dr. Amita Mahajan here on this side. I just want to ask one question. As you are pediatrician, many children come to you with disability. And particularly in India, there is a lot of denial by the parents. And parents are to be motivated by the pediatrician that their child has some problem. How do you motivate them? Because in India, usually parents say our child cannot have this problem or disability. And denial mode is very, very, significant here. How do you motivate what is the role of pediatrician in that? That is very important. How do you motivate them to go for some physician and for the treatment and so on?
Yes, thank you, Dr. Amita. We struggle with the same challenges within the Canadian context. I mean, we do see it more so with families of color or immigrant families, as you might imagine. I think a lot of the awareness campaigns that exist are for kind of mainstream white families or richer families. And so part of that is there's a bit of a knowledge gap. There's also fear of stigma. And I think that that's something we see in many communities across the world, is the idea of when you call it a disability or you give it a name, there is fear of really what is that going to mean long term. And I think some of our approaches have been, when we think about the decisions parents make, including for whether or not to accept that diagnosis, it's a parenting decision, which in some ways is really a health behavior. And so when we think about health behaviors, just like when our colleagues in adult medicine ask people to stop smoking or exercise or eat healthier, saying it once doesn't work. And in the same way, having an approach where the team can come back to parents, give them time to process, honestly, through stages of grief, in the same sort of way where families do need to go through those stages to be able to accept before and get to a point where they've gone through grieving and pain and denial, etc., to get to that point. And I think for some families, some of it is, I mean, we try to connect them with, we have patient partner families who have gone through the experience earlier. So sometimes it's helpful to talk to a family who has gone through a disability diagnosis and now they're 4 or 5 years down the road. And it's helpful for them to talk and see kind of what is this reality like. And so parent support groups are helpful, and also being able to, with us, we try to wrap around and have follow-up visits to help those parents in moving forward. The last point I'll say is, I think for a lot of families, there's a feeling of a loss of control. And as parents, you want to keep your child safe. You want to have some say in where they're headed long-term. And when someone external, like a physician or a therapist, says that your child has a diagnosis or a disability, parents take it personally, of course, but there's this fear that now they will be kind of gone down this track, which is out of control. So a lot of my counseling with parents is really around, what is the control you do have? What is the time that you can take? Even though we know that many of these interventions are time sensitive and early intervention is better, but at the same time, what are the things that you can take some time with to process and reflect and come back? And so we always, after a diagnosis visit, 2 months later, set up a follow-up visit to be able to come back and answer their questions accordingly as well.
Thank you so much, sir, for such a elaborative reply. Thank you. Sir, another question is, as there is corona all over the world, here people even think it stigmatic to be infected with corona, and they don't want to go to hospitals for that treatment. This I have seen in our family, in my family also, family of well-educated people or physicians. And what is the status in Canada? How should we come out? How the physician should come out with some solutions for the same?
Yeah, thank you. It has been similar here in the Canadian context, where I think coronavirus has been met with stigma, right? There is this fear we've seen, honestly, within the Canadian context, because many of our South Asian communities had higher prevalences than the white communities as well. For various reasons, there's been a lot of advocacy, but even within the South Asian community, there has been stigma for who has it, who doesn't, how did they get it, were there hygiene-related practices around it, and of course, there's been a lot of myth busting, we call, so essentially trying to address really what is the truth there. Sometimes it's helpful when we think from a public health standpoint to look at, are there particular champions in the community? Are there people who can speak to the need for this? But there's been so much stigma around, I think, getting tested, sharing your diagnosis with others, especially if you have contact tracing that needs to happen after you are diagnosed with COVID, and then even vaccine mistrust. Now, as we roll out with our vaccines, there's so many communities that are weary and are mistrusting those. as well because of all of this. That's part of why I'll say, that's part of why we've rolled out with, you might have seen on social media, so many more physicians and healthcare providers are going out there, because that's also where all of the myths come. So there's so many WhatsApp forwards and Instagram posts and all of these things about why you shouldn't get vaccinated and why COVID is bad or it's fake. And so I think many people are now trying to drown that out with more evidence-based information as well. So I think it's really making physicians jump into different areas where we were not comfortable or trained to try to really get to people and share information that can impact some change and health. Sorry, you're on mute.
Important in rehabilitation of the corona patient.
Could you say that again? Sorry.
I would say here role of the community and family is very, very important in the rehabilitation of the corona patients.
Yes, yeah. So I think I heard part of the question, but it was around the community and the family with supporting and rehabilitating corona patients. Is that right?
Okay. Thank you.
Okay.
Thank you so much, sir.
Thank you. My pleasure.
Thank you.
Thank you for the opportunity.
So much for such elaborative and informative talks. Thank
you. Till our next speaker be ready, let me invite Dr. Priyanshu to discuss his views with the audience as a chairperson of this conference.
Thanks.
Session.
I guess it is me. I am Prasannanshu. And Dr. Minhas, are you there? First of all, I really liked your approach of culture, community, and communication, 3 C's, and equity. I think these 3 C's certainly see that equity is ensured, and if equity is there, only then these 3 things survive. With these sweeping remarks, perhaps I can say a few more things. That was really very interesting. And you were talking about the community in Canada and also Chandigarh, with your experience in Chandigarh. But I think it is very universal, and I have seen similar things, especially in the context of COVID also. We have seen that in other communities, diverse communities, for example, the Roma community in Europe. I had an opportunity of working with that community to some extent, some research, some conferences we have been doing, collaborating. There the problem was same, of the stigma. It sounded very familiar, like the blame game, or rather the usual suspect always, who is there, why this is spreading in this community, or if you have more cases, and what's the reason. Instead of looking at the basic infrastructure and facilities and education level, people suspect other things. So this aspect is also an important part of pandemics, of healthcare in general, and about equity, of course. It starts with equity, that is justice, social justice, equality, equal opportunity, and ends with that. It's a circular thing. And I was reminded of one example of communication in neuro-linguistic situations, neuro-linguistic problems, issues. I would like to share it. Perhaps I can say it, go before Dr. Jessica, if she allows me. Although, yeah. I remember that one of my colleagues' mother had a stroke, and she was not able to speak. And even in a hospital, she stayed in a hospital for a considerable amount of time. The neurologist used to visit, and they were not able to communicate. Let me focus on this word communication. That whether this person was in coma, was she aware of anything? Was she, was she ever able to communicate with anyone in any way? they were just focusing upon the stroke and how to manage it. And they brought her home, and I visited as a friend, as a family friend, family member, and they were all in distress, and they were trying to communicate with her, talk to her, and they reported that once or twice they saw tears in her eyes, and that's all. And they consider that she is in a vegetative state. Then I used the very basic trick, and I said, all right, you please go out, all the family members, because they were getting very worked up. Hysterical is the right word to use, but and I asked her very slowly, at your pace, I think that perhaps you are able to understand something. Blink your eye once if I say so, something like that. That basic thing all of us know. And she responded. Then I called the family members, and they were convinced that she's not brain dead, she's not in a vegetative state. I didn't do anything, just like any other person. I went and talked. So this is, I think, what is lacking: communication. We have to focus on communication in several aspects. This whole session is about communication in neurolinguistic disorders, in rehabilitation and otherwise. So with the family, I think as medical practitioners, people have to communicate very clearly. Somehow that gap is there. They have to communicate with the patient. They have to find ways of establishing communication between the two in all of these things, whether it is autism, whether it is aphasia, dyslexia, any of the disorders. I think an important focus of the medical community, the rehabilitation community, should be on creating, establishing, supporting, reinforcing the communication bridge. And that will change the lives in a big way. And coming back to Dr. Minhas, he is also for communication between communities. That's what I read under the line, between the lines. And communication with the receivers of medical care. So with this, may I invite Dr. Jessica Stewart to make her presentation on pre-linguistic communication in children with AND. Yes, Dr. Dhanvi, please.
Can I have one question only, Dr. Ipnudaman, before starting this?
You are in the chair, sir. Please go ahead.
Dr. Ipnudaman, we have seen in our PGI, even in our India, the pediatrician mostly, if anybody is having delayed speech or any problem, any delayed milestones, they are not sending those patients to the specialist. Is it the same thing happen there in your country?
We're not seeing it as much here. I think there used to be a practice where there would be a watchful waiting sort of approach. And there was a big campaign around how that is not prudent when we know early intervention is so important. Also within the Canadian context, because we have a public healthcare system, there are wait lists. So I think a lot of the primary care family doctors, nurse practitioners, and pediatricians understand that early identification and referral is helpful. So even if we have publicly funded speech and language therapy, but if there's a wait, it's on people's minds. And one of the big things that helped with that actually is our structured well child visits that we have. So they have these developmental screening measures that are built into the kind of 2, 4, 6, all the way up to 18-month visits when vaccinations are happening. And with that, we've really tried to streamline it so it's easier. I think one of the barriers we have found when we've done studies within our teams in Toronto is that many family doctors and pediatricians were initially unaware of where to refer. So then that makes it harder, right? You may know that there's something that's wrong, but you don't know where to send them. So let's just wait and see. So a lot of it has been outreach and awareness around that. And some of it also is while families are waiting, if they're waiting for assessment from us or with therapy to start, we've created some online resources. So there's something that families can do in the meantime, rather than kind of sitting on the wait list and worrying. Some online and parent education resources have been helpful as well.
Thank you. That's right. Definitely.
Thank you so much, sir. Our next speaker is Dr. Jessica. Welcome, ma'am. Dr. Jessica is an assistant professor at the University of Texas. Her topic is prelingual communication with children with ASD. I request her to share her knowledge with us. Yes, ma'am.
Hi, all. Thank you so much for having me. It's interesting to see that you all are having the same issues in India and Canada with referral for services. I think it's very similar in the United States as well. So I think that was a great question. I wanted to just share really quickly that have you all heard there's a website called Learn the Signs, Act Early, and it's a really great resource for parents that can be used to identify whether or not their child is functioning within normal limits or not, if they're having concerns. But let me share my presentation. Can you all hear me okay?
Yes,
Yes.
Yes, fine.
And
Please continue, ma'am.
okay, I think it's trying to open my slides and it says preparing slides.
Okay, fine. Doing.
I'm not sure why it's not opening.
It will take time. I hope so.
Just a moment, ma'am. Doing.
I'm sorry?
Would you like us to do something for you?
I'm not, this has not happened to me before. Oh, did it start working? The screen is black and it says it's preparing my slides. Let me try a different way. I can share this way.
All right.
I'm so sorry.
It's okay.
Oh, there it goes. I think.
Yes, it's visible.
Let's see. Can you all see my presentation now?
Initially, it was there. Now again.
Okay, it should work this time. Is it working now?
Working now.
Okay, I'm so sorry. How embarrassing.
No
Okay,
problem.
hello. I am Dr. Jessica Stewart. I am from the University of Texas, Rio Grande Valley, and I am going to be presenting today on some research that me and my colleagues are doing looking at prelinguistic communication in children with autism spectrum disorder. Just some really quick disclosures. I don't have any kind of financial or non-financial relationships relevant to the content of this presentation. Like I said, I'm a professor at UTRGV. My primary areas of expertise and interests include autism spectrum disorder, other neurodevelopmental disorders, and early childhood language acquisition. So really quickly, a background on autism spectrum disorder. So as we all know, this is a developmental disability that's characterized by specific persistent impairments in social interaction and the presence of restricted repetitive patterns of behaviors, interests, or activities. In the United States, the gold standard recommendation for diagnosis of autism spectrum disorder is to use a multidisciplinary team consisting of medical doctors, speech and language pathologists, social workers, geneticists, whatever combination of healthcare practitioners is relevant for that individual patient. It is also recommended that we use the ADOS-2 and the ADIR. In terms of prevalence rate, I found this very interesting. So in the United States, the prevalence rate of ASD is currently 1 in 54 children. And I did some research in looking up the prevalence rate of ASD in India, and I found a really nice systematic review that was published in 2019. And the prevalence rate in India is only about 0.11% of children between the ages of 1 and 18 years. Now that's compared, 1 in 54 is about 2% of children. So I found that really interesting. If any of you are interested in doing some research on this, please reach out to me as to why the prevalence rate would be so different in these two countries. Okay, so next, just a really quick background. Children with ASD, we have found, and we do know that they do have delays and differences in their use of gestures when compared to other populations. So research studies have found that children with ASD are using different frequencies of gestures, they have different inventories of gestures, and they develop gestures differently than other populations. So gestures are, in fact, one of the earliest behavioral markers of this disorder. And these delays and deficits can be present even before a child's first birthday, because gestures emerge around the age of 9 months. However, the current average age of diagnosis of ASD in the United States is 4 years, 2.5 months. And in India, the current average age of diagnosis is about 42 to 55 months. So it is very similar there. If we can somehow find a way to use gestures to lower this average age of diagnosis, we can get these children into early intervention sooner, which is known to be associated with better outcomes. Because getting them into diagnosed around 4 it's still too late. We've already missed that window of 0 to 3 with early intervention that we know is so important. So what me and my colleagues did was conduct a systematic review of the literature to compare findings across studies and we were interested in looking at, we had 2 main research questions. We had, do children with ASD use different types of gesture when compared to other populations? And do children with ASD use different frequency of gestures compared to other populations? So we wanted to, in one site, systematically review all of the data that's out there so that we could make some really strong conclusions about gesture use in children with autism spectrum disorder that can hopefully begin to translate into clinical practice. So what we did was we went through the literature. We had 5 primary and 21 secondary search terms that we entered into the 5 major electronic databases, and which were PubMed, Web of Science, Academic Search Premier, PsycInfo, and ERIC. And we pulled all of the published research that we got with these 5 primary and 21 secondary search terms. And this gave us a total of 49,798 articles, which was very overwhelming. So next, what we had to do was read through the abstracts of these 49,000 articles and identify the articles that actually were related to the topic we were interested in. And we also removed any duplicates. This process brought us down to 451 articles total. Next, we did a full text review of these 451 articles, and we reviewed them to see if they met the inclusion criteria for our study. So what we were interested in is only peer-reviewed studies. We wanted the studies to look at children with ASD between the ages of 6 months and 6 years. We wanted them to use a comparison group because we were interested in how children with ASD are using gestures in comparison to other populations. And they had to somehow look at gestures in their study. So after this full text article review, we had 32 articles. And then we did an ancestral search. So we reviewed all of the references in those 32 articles to see if we had missed anything. And we did not identify any additional articles. So this is a flow chart that briefly describes what we did. So we started with 49,798 articles and we narrowed it down to 32. Then we coded all of the articles. We double coded all of them for, we collected basic study information, which was like the authors, the year of publication, information about the participants, so SES, parent education, race, gender. If you all are interested, I can give you more detailed information about this later. I'm trying to hurry because I know I have a short amount of time. So once we coded all of the articles, we got the results and we had to synthesize the data. So what we did was we had a ton of information and we didn't know how to organize this information. So first, we tried to separate the articles, which articles looked at gesture type and which articles looked at gesture frequency. So if an article looked at gesture type, we said they were somehow looking at the presence, absence, or specific attributes of gesture, whereas frequency was a measure of quantity of gestures per given time period. So of the 32 articles that we have that met inclusion criteria, 9 of them looked at gesture type, 17 looked at gesture frequency, and 6 measured both gesture type and gesture frequency. So then we tried to look for some common themes. And what we came across in reviewing the articles and the results that we found was that there were 3 common themes that we could use for comparison of the results across studies. And these included comparison group, age of participant, and gesture terminology. So now I'm going to go over the results. I've categorized this I've divided them into the 2 subtypes, gesture type and gesture frequency. So first I will go over the gesture type results. So for the gesture type results, there was 15 studies total. 14 of these 15 studies found that children with ASD are using significantly different types of gestures when compared to other populations. So this is a major finding. Almost all of the studies that looked at gesture type found that children with ASD are using different types of gestures when compared to other populations. This chart here is a representation of the comparison groups that were used in those 15 articles. So across the studies that did look at gesture type in children with ASD, the most commonly utilized comparison group was typically developing children, which is represented here in the green, followed by developmental delay or developmental language delay, then PDD, NOS, and then intellectual disabilities. So this was a really interesting finding, and I'll talk about this a little bit later. Next, we broke down the results by, okay, well, so we know that children with ASD use different types of gestures when compared to other children. We know that most studies are comparing these children to typically developing children. So then we looked at the age of the children that they were studying. This was a very interesting finding to me. So the gross majority of the studies were examining children with ASD between the ages of 4 to 5 years, which is directly in line with the average age of diagnosis of ASD. So this kind of made me wonder, is our average age of diagnosis of ASD around 4 years, because this is the population that's being studied most in the literature? Do we need more studies examining our younger populations? If you look, the least studied population was children 0 to 1. So there was only 2 studies looking at this, and 1 to 2 was only 3 studies, and 2 to 3 was only 4 studies. Which is really interesting, when we're talking about gesture use in children with ASD, because gestures are known to emerge around 9 months of age. So most studies are examining older populations of children. The last significant finding that we found for the type articles was that the gesture terminology was all over the place. So in the articles, in the 15 articles that looked at gesture type, there was 38 different terms used, of which 30 of them were different. So this made comparison of the results across the studies very difficult. And this could be very confusing to healthcare practitioners who are trying to translate research findings into clinical practice when there's so many different terms being used. So this is something I'll talk about a little bit more when I get to the end of the presentation. This is just a huge flow chart that we made. I can share this with you all if you're interested in it, but it just breaks down the results into participant age, comparison group, and the gesture terminology used, and the authors. Okay, so, and then lastly, for the frequency results, so 23 of the total studies met the inclusion criteria for frequency. The results for frequency of gestures were really mixed. So unlike the type results that were very consistent, the frequency results were mixed. So some studies were finding that children with ASD use more gestures than other populations. Some studies were finding that they use less gestures, and some were actually finding no difference. And so this made comparison of the findings across studies once again difficult for us. What we did do was an ad hoc analysis of the studies that did in fact find significant differences. And of the studies that did find significant differences, most of the time children with ASD were gesturing less than the comparison group. Only a few of the studies found that children with ASD to be using more gestures. And this depended on the type of gesture being examined. So gestures being used for behavior regulation functions, like to have someone do or not do something, were being used more frequently than the social interaction gestures and the joint attention gestures. And this is something that we hope to explore in a little bit more detail. So once again, with the frequency articles, typically developing children were the most studied comparison group, followed by developmental language delay, intellectual disabilities, and PDD and OS. Once again, too, the most studied age range was children 4 to 5 years, and the least studied age ranges were children under the age of 3, which is surprising again. And similar to the results for our type analysis, there were 62 different gesture terms used across those articles, which made comparison of the findings across studies, very difficult. And I'm going to skip over that. So our conclusions, what does this all mean? Children with ASD are in fact using different types and frequencies of gestures when compared to other populations. These are early indicators of this disorder. And it was really interesting that the majority of the research is being conducted on children 4 to 5 years of age, which is consistent with the average age of diagnosis. So we really need to have more research looking at younger populations if we're going to start to use gestures as an early indicator of this disorder. The most frequently used comparison group was typically developing children. More studies need to be conducted using other populations of children so that we can engage in differential diagnosis and know how children with ASD are using gestures when compared to more diverse populations. And I've already talked about age range, and there is a huge need for consistency in the gesture terminology. If we could come up with standardized terms and definitions for gestures, I think it would help researchers and clinicians a lot, especially when considering translating our research findings into clinical practice so we can lower the average age of diagnosis of this disorder. And these are the references. And I hope I didn't go too far over my time slot.
I think that was fine. And that's really wonderful.
Question, please.
So, yes, I was just saying that this is interesting. Can you hear me?
Yes.
And I think we can even look at it from this perspective that it is more about the nonverbal part of communication. And in nonverbal communication, eye contact, facial expressions, posture, all these things are there also. So I know that your scope is very well focused. You were working only on gestures, but have you come across some work which is talking about all these things also? I am aware about eye contact, of course.
Yes, there were a lot of studies that looked at eye contact, facial expressions. Something I am very interested in children with ASD that I have not seen much research on is the social smile. It's really interesting, and I think this is. I think you make a good point. It's not just gestures; it's overall nonverbal communication, and but it is difficult. So the reason why we decided to only do gestures for the systematic review is that it is hard to quantify eye contact and a social smile or proximity, but those are definitely very interesting areas, and I think that the literature would benefit from much more research in those areas.
I have in fact guided some research about eye contact and also about proxemics, distance.
Yeah.
Gestures is and touch also. That haptics, where you touch, how frequently, who initiates. So many such things are possible.
Yes, it's very interesting.
Thank you.
Thank you so much, everyone. Is Dr. William there? Dr. Sonika? Dr. Sonika Bakshi? Are you there, ma'am? Dr. Sonika? Are you there to present?
Can I ask one question, Dr. Sonia?
Yes, sir.
Can I ask one question from
Yes,
Jessica?
sir. Yes, sir. Jessica, yeah.
Jessica, it was excellent presentation, really. You are talking about the behavior of the autistic children. Have you compared even a single any child with mean length of utterance words jo hota hai, that anything you have compared or observed any difference between the behavior and MLU of these autistic children's?
I'm sorry, I missed, you said when compared to which population?
Any population, mean length of utterance, we call it that words. How many words that child of 4.5-year-old of autistic can use the phrase like, yes,
so
sentence or...
Yes, I myself have not conducted any research looking at like the MLU or the sentence length or complexity of children with ASD. I do know that there's a rather large body of research out there though, and it really does depend on the severity level of the children with ASD, which and then we can open a whole new can of worms, right? But generally, children with ASD do have less complex syntax and morphology, and until you get to the higher levels, then it kind of changes a little bit.
That's right. So, which scale you use mostly when you diagnose as a autistic ASD?
So I prefer to use the ADIR and the ADOS. It's the Autism Diagnostic Interview Revised and the ADOS. And I was looking, I think that they are available and translated in multiple different countries. Which scale do you all use? I was really interested.
We are using CARS.
The CARS, the Childhood Autism Rating Scale.
Yes, that is the main we are using. So we can do some research here with the Indian population or with your population, some comparative project we can do with the Raat and Bara University to our
would love
PhD.
To do something.
Yeah.
I would love to do something. Yes, I would love to. It would be so interesting.
Yeah, because we are in Punjabi using the language, then whatever our Punjabis are living in your country, that we can try to compare that.
Yes,
we need that type of research here in our India.
Yes, definitely. I would be very interested in working with you to do that. I also find it really interesting why the prevalence rate would be so different if it's a matter of identification or the instruments being used, or if it's over-identified. It's obviously, in my opinion, over-identified in the United States, but I just find that so interesting.
You are working in some government institutes or you're private practitioners?
I work for the government at the university, so, but I was also a private practitioner before.
Before that, okay.
Yes.
But now though they are not allowing you, maybe for the private practice, when you are in government setup. In India, we don't allow to do private practice. Is it same?
No, well, I'm allowed to work in private practice if I want to, but it can only be so many hours. So they limit the number of hours I'm able to.
That's good. We can plan some project along with this Raat and Bara University for a PhD student.
Yes, I would be very interested in doing that.
Thank you very much for your excellent presentation. Thank you.
Thank you for having me. The pleasure was all mine. I will put my email in the chat.
Okay. It's okay. Bye. Thank
you. Dr. Prevalence, Vice Chancellor of Aerosol University, wants to ask you some questions. Please.
Thank you very much, Jessica. Can you hear me?
Yes.
Thank you very much, Jessica. So first, on behalf of Raat Bara, we are very fortunate to have a very thoughtful this topic. It was really very amazing. and the work which you have done. That's really useful. So I just wanted to convey my thanks and do offer you that whatever research is going on there, Riyadpara would be, as Dr. Dharamveer was telling. So do share some platform with the Riyadpara University so that our research scholars or our teachers, they can collaborate with good work, particularly rehabilitation department, which we are going to set up, where a scholar will be enrolled for their PhD as well as for other courses. So thank you very much, Jessica. It was nice to hear you.
Excellent. Thank you very much.
Thank you, Dr. Jessica. Dr. Neena wants to ask you something. Yes, Neena, ma'am.
Good evening, Dr. Jessica. It was really nice, your presentation, and it has given us so much of information. I just wanted to know a few things that in case of ASD, in India, we had a bit of experience with ASD children whom we helped with the like music therapy. That was starting from like early age, and by the time that child grew, for example, he started from 4 to 5 years. In India, we have like a rich culture of classical Indian music, and that sometimes really works very well, but not many are coming into this field because there is, like, although India is rich in this culture of classical music, and it has so many frequencies being used in different, we call it as swaras, right? So these frequencies, and the child, otherwise not communicating with the society, but he was able to communicate through, music. He was able to learn the ragas which we as adults could not. Sometimes it is difficult for us to understand because there is so much of restriction in the ragas that we have some rules and regulations, and these children, even of younger age, otherwise they are not very communicative to the society, but was able to express and understand the beats and everything so well. So it's sometimes these different types of therapies, they really work very well. So I want to know, like, exactly how, what is your field of research in your area?
That is really interesting, and the music therapy is kind of fascinating. There's a growing body of research surrounding that, and I think you bring up a good point with the cultural differences with how music therapy is. So how music is more important in different cultures. That's something really interesting to think about. My primary area of focus when it comes to children with autism spectrum disorder is on early identification and diagnoses. I haven't yet done so much research in terms of the intervention, but that doesn't mean that I wouldn't be interested into collaborating with something, but I do think that you bring up a really interesting point there.
Thank you, ma'am. It was really good interacting with you. And if by chance we are like working in the field of rehabilitation and also through music therapy, I think Ruma has been contacting you for this conference. So she is working, she's a music therapist also. And I think we can have more exchange of ideas with you, and we can associate for better understanding of how to treat these types of autism spectrum disordered children. Thank you, ma'am. I think the next speaker is there, so I won't take much time.
Amita wants to ask you something.
Good evening, ma'am. I just want to ask one question, ma'am. There are so many autistic children in India also. What is the reason, whether it is congenital disorder are disorder, science behind it.
Sorry, I think the screen froze. Can you repeat your question?
Ma'am, artistic children, there are so many artistic children in India also. What is the reason of this, whether it is congenital disorder or the genetic type of disorder, or sometimes reason is not very clear, but do you think what is the reason of this disorder?
So the research looking into the cause of ASD is still, there's still hasn't been one cause identified. There's a general consensus right now that it's a neurodevelopmental disorder present from birth. I did see some really interesting research recently, and I can't, the name of the researcher is, I can't think of it right now, but he actually found, he looked at brain samples of individuals with ASD, and he found that they have fewer connections in certain areas of the brain when compared to typically developing individuals. And I found that work really interesting. In terms of the genetics, they haven't been able to find just one gene. There's been a number of different genes that have been identified as possibly causal in terms of ASD. Something that I always like to rule out is when making a diagnosis of ASD is Fragile X, which is you can test genetically for that. But I guess still we aren't totally positive, but I do believe it's something neurological.
Thank you, ma'am. Thank you so much. Now I hand over to the moderator of this session.
Thank you, ma'am. With permission of our chair, can I call our next speaker? Dr. Olaf is there.
Yes,
Yes,
go
sir.
ahead.
Yeah,
William has
thank you so
come.
much. Our next speaker is Dr. Olaf from Canada. Welcome, Dr. Olaf. Dr. Olaf is an associate professor in McMaster University. His topic is the ethical dilemma of diagnosis during care delivery. Sir, please share your knowledge and experience with audience. Yes, sir.
Well, thank you very much for your kind invitation and introduction. Let me see if I can make this work here. I'm actually right now in Germany at the home of my parents, and I'm not sure how well the internet will work. So let's keep fingers crossed. Can you see the full screen?
Yes.
Good. Okay, good. So my topic is the ethical dilemma of diagnosis-driven care delivery, and I think I have 15 minutes, so I will jump in directly into the presentation. Let's start with two of my patients that I'm following already for a long time. The first one, let's call him Adam, and when I saw him at 6 years of age, he had a history of started walking with 3 years, running with 4 years, was struggling with fine motor difficulties, with printing, self-help skills. He had quite well-developed speech, growing up bilingual, and a good academic performance. Socially, he was a bit shy and awkward, but he reportedly had some friends. The other patient I want to present to you, I called her Eva. At the time, she was 5 years old. Since the age of 2, very demanding and explosive behaviors, inattention, hyperactivity, impulsivity, oppositional, defiant, lots of behavioral problems, had difficulties learning to read, sometimes was violent towards her older siblings, was stealing from peers and siblings, had few friends, and a speech delay. So if you see just these short descriptions and try to come up with a diagnosis, let's look at what we mean by diagnosis. And the previous I couldn't see the whole previous talk. I was still busy with other things, but I know it was about, or we were discussing autism, and that is one of the difficulties when we try to find a diagnosis. So the word of diagnosis actually means the ability to tell things apart. So is that what does Adam have? What does Eva have? And we rely on collecting a lot of information. We rely on the history, on exams, on tests sometimes. And that's a process where we develop a hypothesis and then try to verify that hypothesis with further tests and further exams until we come to the conclusion, this is autism or this is some other condition. And I like to compare that to a process of a sculpture. And there's a famous quote from Michelangelo when he was asked how he did that beautiful sculpture of David. And he said, well, I saw the angel in the marble and carved until I set him free. So I saw it there, and then I took away everything that was not part of it, and what rested was the angel in the car, not David in the statue. And so that is the process that we usually do. And I found a statue from India here for this talk, but it is a similar process. You go and rule out all the things that do not match with the diagnosis until you come up with a diagnosis. And in the case of Adam and Eva, at that time, at that age, Adam was diagnosed with a developmental coordination disorder, and Eva was not so clear, so she had a lot of different mental health diagnoses: oppositional defiant disorder, ADHD, a query of fetal alcohol spectrum disorder, a query of a learning disability, query of obsessive compulsive. So lots of queries and questions, and more tests and exams had to be done for her. When I saw them later on at the age of 12 years, then Adam has a diagnosis of autism spectrum disorder, high functioning. He continues with his motor coordination difficulties, was also diagnosed with a non-verbal learning disability, and he was going through his first episode of depression, which has repeated since then, becoming more aware of his limitations and difficulties in relating with other people and making friends and fitting into the school. And Eva was eventually diagnosed with fetal alcohol spectrum disorder and continued with a list of mental health conditions as well. So we have done here the picture of two children with two main diagnoses, one with an autism diagnosis, the other with a fetal alcohol spectrum diagnosis. And what I'm relating here now is the reality in our province in Canada, in Ontario, and it's about to change, but that is the status quo when I prepared that. It's just being changed right now, but at the moment it was, the government had an Ontario autism program, and to receive treatment or receive services, the requirement was that the child needed to have been diagnosed with autism by a physician or a psychologist. The parents then had to register in the Ontario Autism Program. They would receive money according to the age of the child, under 6 and over 6 less money, under 6 more money. And then they were sent out to find services and providers where they could then use the money to obtain treatment for behavior problems, mostly ABA therapy, but also other therapies were covered by that. If you look at a similar web page, also funded by the or supported by the government of Ontario for FASD, or fetal alcohol spectrum disorder, and I put in their website looking for behavioral therapists. That was the answer I got. No results found, please try again. So there was nothing, and there's no budget for these families. There's no services. There's very little for them to connect with. So we have in this case 2 children with complex diagnoses with different difficulties, both in the learning in the learning sector, in the social interactions, in the mental health realm, and one of them receives a lot of services, the other hardly any. And this conference is about the ethical aspects of what we do in healthcare, and 4 elements we need to consider when we talk about ethical decisions or ethical consequences of our work. So one is the respecting the autonomy of the patients and the families in deciding what they find is best for them and their children. The aspect of beneficence, to really do good, to benefit the child and the family in some way without causing harm. That's the non-maleficence. And the last and important aspect for this case here is justice. And the justice aspect in ethical decisions is that it relates to the fair distribution of scarce resources, respect for people's rights, and respect for morally acceptable laws. So in that sense, the situation we have right now is not really fair, is not really just, because we have children mostly the same age with significant difficulties regarding the development that need rehab and treatment services, and one can get it and the other not. So what can we do when that happens? And first, before we go about what we can do, let's talk about why is that initially difficult. And I think one of the reasons is that these conditions that we see are complex conditions. They are not just a single pneumonia or a broken leg or something very simple without wanting to reduce what the colleagues in these areas do, but we have various aspects of complexity that we need to deal with these patients. And in this article, the authors have a very nice description or definition of what is the complexity or how it is caused. It's the intersection between the individual and their environment. It's not only the individual child that needs treatment, but it's the whole environment that needs to be included, the school, the family, the teachers. And that makes it more complex. So,
Dr. Ola?
Yeah?
Actually, your screen is not moving. I think it's frozen.
Oh.
Thank you. I'm sorry to disturb
Sorry
you in
about
between.
that.
I'm sorry to disturb you in the between.
No problem.
Thank you. Thank you so much.
I'm clicking here on resume share. Now I see it, yeah. We stop share and start share again. Sorry about this.
No worries, no worries. Yeah. Technical glitch happens sometimes.
Yeah. You see it now?
Yeah, we can see that now.
Okay, I'm very sorry about that. Yeah.
No worries, please. Thank you so much.
Okay. So I continue from here. So here we have the individual aspects and the environmental aspects that contribute to disability and to complexity. So we have people with multiple impairments. Sometimes, in this case, it was not the case that I showed, but often we have people with profound intellectual impairments, but then also coexisting mental health issues, other health conditions. There might be behaviors that are complex. Experience of trauma or neglect might be an aspect, and then the environment might be the socioeconomic disadvantage, social isolation, a lack of service coordination. That's actually what we are dealing here with, and lack of cross-sector collaboration. So when we look at that part, let me go a step back, and I don't know how well Harry Potter was sold in India. This here is Lord Voldemort from the novels of Harry Potter, and I put him in there as a figure that, in my experience, symbolizes quite well significant diagnosis. So his name is He Who Must Not Be Named, and my background is German, but I grew up in Brazil, and in Brazil, I often heard from elderly people avoiding certain diagnostic terms. So you wouldn't say that a person has tuberculosis, or you wouldn't say that a person has cancer. That was not to be used, that word, because it must not be named. So such the importance of a diagnosis in that culture, in the Brazilian culture. When we think about disability, disability is more an experience, is how you get along in life. And all people can find themselves in disabling life situations. So I'm right now not wearing my glasses because I cannot see you at this distance, but in other situations I need my glasses. So without the glasses, I'm disabled. With the glasses, that is corrected or can be prevented. So in relative terms, disability is something that can be prevented if you provide the supports that are necessary. And these relations between the disability experience and what we call functioning, when things are going well and you can do the things that you want to do, these are quite complex. So in that sense, going back to the idea of a sculpture to making a diagnosis, I liked the example of a mosaic when you try to describe a functioning level of a person. So what are all the elements that make you as a person being functioning and being participating in the life, or a child with a disability? What are the elements that make that child functioning? And it is, if you just know the diagnosis, you actually don't know anything about how this child is functioning. You just have one label. And the mosaic pieces that we can use to describe that level of functioning is the International Classification of Functioning, Disability, and Health. That's a classification created by the World Health Organization with the idea to complement the International Classification of Diseases. And it has main elements. These, you can imagine them as main boxes, and each of these boxes has little stones in those boxes with other shapes and other colors. So is the box for body structures and functions. That's the box for activities. There's a box for participation. And then we have the environmental factors and the personal factors, what makes the person unique. And just a quick description of all these elements here. So the body function and structure is, I think, quite obvious from the name. Activities are the tasks that somebody does, like I am able to walk. But participation would be the involvement in the life situation. I walk to school, I walk to the grocery store. And the environment is then the environment that allows me to walk to the grocery store or that hinders me in doing that, depending if that's a paved road or not, or if I need a wheelchair or not, and so on. And personal factors are the aspects that make you unique as a person, your gender, your age, your beliefs, your values, and so on. So when we look at this aspect, which is more holistic, and look at functioning, this is an aspect that or a definition I like from Huber and colleagues from the Netherlands, defining health in a new way, defining health as the ability to adapt and self-manage in the face of social, physical, and emotional challenges. And in that sense, functioning could be understood as the evidence of health. So it's a different approach. It's not the absence of disease, but it's the ability to function makes you be a person that is healthy. And that actually is valid for all of us. We all have some limitations than others. And when we feel fine, then we are healthy. So it remembers me, my grandmother, when I asked her when she was over 80 and had cancer and had a stroke, how she was doing, she was, I'm doing fine. All the elements that I have are part of age, and that's how I function. And I don't complain about anything because I feel healthy now. So that's a very healthy relationship to her body and her illnesses. So how can we measure functioning? This is just a short example. That's an example from Adam's chart, and only a piece of it. That's a tool called the PediCat, and it has a list of different elements, what you do, what we can all relate to functioning. This time is, and this element here is organization and planning, but you have it for mobility, you have it for communication, for different aspects. And here it shows some of the elements that are more difficult for him and others that are actually strengths for him. So that puts together the different elements of how he is functioning in different areas. And to finalize, what I would like to come to is a short, small study that we did last year. Was a chart review where we went through the charts of patients that were matched by gender and age over the last year, 25 children in each of the groups. And we just documented or extracted out of the reports which were the main complaints, the main issues that parents brought up in the last visit to our clinic. And one group were children with autism spectrum disorder, and the other group were children with fetal alcohol spectrum disorder. And when we map all these concerns that children had or parents reported about their children in our visits, we come up with what we can call a spectrum of functioning. So these are the two groups that you can see here. My screen is a bit covered now here. You have the ASD group and the FASD group, and you can see that each of these vertical lines is one of the children. Each of them is different from the others. Some have overlaps, but if you look at the two broad groups, there is really not a big difference between them. So it is to demonstrate that despite different main diagnoses, often the needs that children with disabilities, in this case ASD and FASD, present to us might be very similar, and it might be more sensible to organize services according to functional needs and functional profiles of patient populations than just based on a diagnostic label. And more parents are now also requesting that this happens in Canada, and there's a movement for needs-based services so that you're not linked anymore to a specific diagnosis, but to the needs that can be identified with different tools. For example, the PediCat is one of them. So I come to the conclusions. I tried in this short presentation show you that a functional profile informs more about the needs of an individual patient than their diagnosis, and that capturing a functional profile of patient populations has the potential to better identify service gaps and design supports that are equitable and fair for the whole population, and that healthcare professionals that expand their thinking beyond the biomedical model towards a biopsychosocial, and some colleagues also add spiritual to that model of the ICF, that this can contribute to an ethical delivery of care. So I thank you very much for the opportunity to speak to you, and I hope I made it in time, and I'm happy to answer any questions or discussions.
Thank you so much, Dr. Olaf.
Thank you.
Can you please, can I make an observation?
Sure, yes.
Dr. Olaf, I'm not going to your full name. I will need training.
That's okay. I always go by Dr. Olaf.
Same with my name. Yeah. So it's very fascinating philosophically. And I think philosophically, or in the realm of thinking, we really make a lot of difference. Like what your approach is, I listen to it with great interest. And that approach, according to me, is of definitions, maybe avoiding definitions. And I am reminded of Derrida. He said that naming is originary violence. So yes, perhaps we are committing this violence many a time upon ourselves and upon people who are under our care. So it is certainly better to look at, I am with you, we should look at the issues. We should not label the whole person as that disease or with that disease or that disorder, disability. So only some aspects, perhaps 1%, even in autism, is affected. 99% of the person remains very functional, very inverted commas normal. Good. Thank you.
Thank you very much. Could you send me that definition, what you mentioned at the beginning? I would really like to take note of that, or put it in the chat.
Yeah, naming is originary violence. Let me post it for you.
Thank you.
Thank you so much, sir. With permission of chair, can I present photo clients, sir?
Sure.
Dr. Priyanshu, would you like to say something?
If you allow me, how many minutes? We are teachers, we need minutes. So, all right, 2 minutes. Is it fine for you?
Yes.
So, first of all, I congratulate Rayat Bahara University. I have been very lucky to be associated with the university, with all of you. And my very special thanks to Dr. Dharamveer. I think he is the driving force behind this these events. There's a whole chain of things he keeps doing. And I'm lucky that I am associated with practically all of his endeavors and the endeavors which are being done at Rayat Bahara. The hospitality and the warmth of Rayat Bahara lingers in my mind. And I hope that after this pandemic, we will have a chance again to meet. Having said this, I think this session, in which I was given the opportunity to be a co-chair with Professor Dharamveer, was really wonderful because that is very close to my heart. In this session, we were focusing upon communication disabilities, challenges, and ways out, and different approaches, especially philosophically, how to look at these problems. And the last speaker, I think, really summed it up, according to me, that how to look at the problem. The problems are there. Perhaps we all have a problem. I have a problem. I can't fly. I can't even swim properly. So there are limitations, but I feel perfectly normal without even being able to fly. So I think I am in tune with what you are saying. There are things in our lives. I just try to make up a very spectacular example, but otherwise also we all have our limitations. Rather, the philosophical trend in rehabilitation, in medical care, and for people who have challenges or some spectacular challenges should be this. This should be the future. Perhaps this is the tune that, or this is the direction that we should take home from this conference. First of all, how to look at, how to visualize, how to put it in perspective, a disability, disorder, or challenge, and then how to deal with life. Thank you very much.
Thanks a lot, Dr. Priyanshu, for your informative words. It is an honor for me to give a vote of thanks on this occasion of conference. On behalf of Riyadh Bahara University and the entire management, I express my heartiest gratitude to all the guests and speakers for sharing their graceful words with us. I'm thankful to all the participants for attending the conference. I'm also thankful to the organizing committee for their support. We will meet tomorrow again as per the schedule. Once again, I thanks to all. With permission of chair, can I end this session?
Yes. Good.
Dr. Priyanshu, please, can I end this session of conference?
Certainly, thank you very much. And people who I have not named personally, I thank them also.
With this, we have successfully completed the first day of the conference. Now I invite Dr. Neena Mehta to thank everyone. Neena Mehta, ma'am, please.
Good evening, everybody. Thank you, Dr. Prasannanshu and Dr. Dharamveer for successfully chairing this session. And it is really very nice to have you here, sir. Dr. Prasannanshu, when I last had interaction with you on our guest lecture in the field of rehabilitation for our rehabilitation research students, it was really very interactive session, and we all had a very wonderful experience with you, sir. Now on behalf of our worthy Chancellor, Sir Sardar Govinder Singh Bharaji, our worthy Vice Chancellor, Sir Professor Dr. Pravinder Singh Ji, and all University, I extend the vote of thanks to all our experienced speakers of the day, and with very successful event of the day now coming to an end, and the most eminent personality, Professor Dr. Surinder Kashyap, who inaugurated the session, who is also the Honorable Vice Chancellor of Atal Medical and Research University, Himachal Pradesh, India, and Dr. Jaswinder Singh, Director Principal of Government Medical College, Chandigarh, and the other senior dignitaries, Dr. Saraswati Gupta and Dr. Jayamanti Bakshi from PGIMR, who is also co-chairing this conference. So we all are very honored to have all the eminent speakers from India and abroad, from US, from Canada, and there are others from Australia, Hong Kong. So we are very happy to have all of them here for this special event on rehabilitation. I welcome all the dignitaries who were here, and also I thank them for their graceful presence and their graceful presentations. Sir, I at the end again request and Professor Dr. Daljit Singh ji, who is over here to shower his blessings on us, and we all are indebted to him for his guidance and always with us wherever he is. Thank you. And I end this session here. Thank you so much. See you again tomorrow. We'll see you in the morning, and the session will go in late evening like today. Thank you so much. Thank you all. Good night.
Good evening, Daljit sir. Good evening.
Good evening. Thank you. Thank you.
Bye-bye.
Bye. Thank you, sir. Thank you, Dr. Olaf. Thank you.
Thank you.
Bye.
Thank you, Dr. Olaf.
Thank you very much.